Hello everyone, and welcome to our program entitled Managing Pain in Your OA Patients, a Multidisciplinary Approach. My name is Dr. Chris Chappel, and I have a primary care practice in Kissimmee, Florida, seeing patients in the office and at several nursing home facilities. I'm here with my colleague, Dr. Andrew Sulich, who is a rheumatologist practicing in Michigan. Today we are going to share our experiences in managing OA-related pain. The objectives of today's presentation are to provide an overview of the challenges in managing pain in patients with OA, discuss the role of primary care physicians and rheumatologists in managing this pain, and educate healthcare providers on the use of OTC analgesics for managing OA-related pain. I'm going to start off by giving you a primary care perspective on OA, describing what this disease means to me as a family physician. Dr. Sulich will follow up by sharing a rheumatologist perspective and provide additional insights on pain management options as a specialist. Let's start with an overview of what I'm going to cover today. First, we will look at some typical osteoarthritis patient profiles that you might see in your office. We're also going to look at what this disease process means to a practicing primary provider. We're going to determine how we reach that diagnosis. We'll discuss formulating a treatment plan using non-pharmacologic and pharmacologic treatment options. Then we'll get into the meat of things. We're going to really look at when to consider the use of over-the-counter analgesia for the management of OA pain and review the challenges, side effects, and safety considerations when making a recommendation. And finally, we're going to revisit these patient profiles and use what we just learned to determine a treatment plan for these patients. Let's begin by looking at our patient profiles. Our first patient is a 72-year-old female who has hypertension, diabetes, dyslipidemia, but no known coronary artery disease. She has stage 3 chronic kidney disease with a GFR of 52. Her major complaint is, "Doc, my knees are killing me." Her current medications are lisinopril 20 milligrams a day, metformin 500 milligrams twice a day, insulin detamir 15 units at night, and a preventative 81 milligram aspirin. The second patient is a 59-year-old male who has coronary artery disease and had an MI 2 years ago requiring stents to be placed. He is obese with a BMI of 31. He's also depressed. That has led him to abuse alcohol, where he admits to at least 4 drinks a day. He continues to smoke cigarettes, although he did go from 2 packs a day down to a half a pack a day, and feels that to be quite an accomplishment. The main reason he's come to your office today is, "Doc, my back is killing me. I've got pain there and I seem to have spasms at times." His current medications include metoprolol 12.5 milligrams twice a day, clopidogrel 75 milligrams a day, 162 milligrams of aspirin a day, and fluticasone salmeterol 250/50 1 puff twice a day. So how are we going to effectively and safely manage pain in these patients? Well, that's what we're here today to learn. Osteoarthritis is defined or characterized by the breakdown of cartilage, joint lining, and underlying bone within the joints. Remember, this is a joint disease. It's the most common form of arthritis. Probably half of Americans at some point in their lifetime will have complaints of osteoarthritis pain. It's the most prevalent in spine, hand, knee, and hip. It's estimated that almost 30 million Americans are currently living with osteoarthritis, and females have a greater risk than males in developing this disease. This slide depicts the prevalence or location of osteoarthritis in the body, where the spine is the predominant area involved, followed by the hand, the knee, and then the hip. So what's the impact of osteoarthritis? Well, there's a patient burden. It causes pain, which can affect their quality of life, sleep, activities of daily living, work, and hobbies. Then there's an economic burden. Individually, over $8,000 per year is spent on the treatment of osteoarthritis, both directly and indirectly. And job-related expenses, including absenteeism, workman's comp, decreased efficiency, and decreased productivity, can reach in excess of $13 billion. This is not a disease state that can be taken lightly. What do I look for when I'm diagnosing this disease? If we look at the pathway we travel down, we know that these patients are typically over 50 years old. They have a gradual progression of disease. This is not a disease that a person walks into my office with a red, hot, swollen knee. This is a gradual, progressive disease caused by repetitive activity. So you see it in laborers, athletes, and in people that use their hands constantly. Osteoarthritis wears and breaks down the joints. The lab results basically tell you what it's not. A SED rate is normal. The rheumatology workup that we do is normal. The uric acid is normal. It's basically a diagnosis where we've ruled everything else out, and now we're left with osteoarthritis. If you take an X-ray, the results may show some joint space narrowing. You might see some osteophytes around the joint area on the bone itself, but the X-rays could be totally normal. During the physical examination, you may see multiple joints involved in this disease, but the patient is primarily going to complain of one or two joints, which is the reason they made the appointment in the first place. During the physical examination for these patients, there may be some stiffness, and the patient says, boy, you know, it's far stiffer in the morning when I first get up, but it seems to work its way out and is more tolerable as the day goes on. They describe the pain as an aching pain, and when you put them through the range of motion, they'll say, gosh, that's it. It's kind of an ache, doc. It's not a sharp stabbing pain. They'll have loss of flexibility and decreased range of motion in the joints that you're testing. You may even hear or feel crepitus, which is the crunching sound when you put that joint through the range of motion. Then at the joint itself, you'll see some bony enlargement and some bony tenderness. Again, what you don't see is a red, hot, swollen joint. What you don't see is systemic manifestations of this disease. This doesn't involve the heart or the lungs or the kidneys like you see with diseases such as rheumatoid arthritis or systemic lupus. Now that we have a better understanding of what OA is, let's formulate a treatment plan. Let's look at both non-pharmacologic and pharmacologic treatment ideas that I consider. Starting with the non-pharmacologic treatments. If they're overweight, start by encouraging them to lose weight. This will reduce the weight-bearing load on a joint, especially in the back, the knees, and the hip. And don't forget, proper shoe wear is so important. A lot of people with osteoarthritis will avoid exercise because it hurts, but low-impact exercise is important. This is not the kind of patient you would recommend training for a marathon. You're looking at light aerobic exercise like walking or jogging on a treadmill. You might recommend non-weight-bearing aerobic activity like bicycling or water aerobic classes. Tai Chi and yoga may increase flexibility, increase range of motion, and relieve pain. I encourage resistance training, which means lifting weights. But keep in mind, these are low weights with full range of motion. You want to build up the muscles that protect the joint. Thermal therapy is an option, either an ice pack, a heating pad, topical ointments or gels. The combination of heat first, then ice afterwards can be a nice thermal therapy for these patients. Physical therapy and occupational therapy may help decrease the progression of the disease and increase the range of motion of the joints. The therapist can help with lifestyle adjustments and the use of assistive devices such as the cane or a walker. Braces, wraps, and shoe inserts can be recommended by a therapist, chiropractor, or even a podiatrist. Transcutaneous nerve stimulation, the TENS unit, is another pain control option, along with needle and non-needle acupuncture. If that fails, or if that's not enough, then patients are going to require medications. The over-the-counter non-prescriptive types are your acetaminophen and your NSAIDs, specifically aspirin, ibuprofen, or naproxen. And there are some natural products, glucosamine chondroitin, omega-3 fish oils, and avocado soybean supplements that have been thought to decrease the pain of osteoarthritis. If they need some additional pain relief, prescription NSAIDs are possible choices with regards to effective pain relief in this disease state. I like the use of muscle relaxants, especially in patients who have concurrent spasm in their back or around the hip. Be careful of sedation with this class of meds. Use these at low dose and for a short term. Educate patients on the side effects of these medications as well. SSRIs or SNRIs can be used when anxiety or depression is present. There are also certain ones that have an indication for pain, like duloxetine. Topical therapies like capsaicin, diclofenac, or lidocaine patches are also options that can be used directly on the most painful joint. Then we have controlled substances. Be careful with these because they require monitoring for side effects, addiction, and abuse. Tramadol was just made a Class 4 drug, so it's under the controlled guidelines as well. The opioids like hydrocodone, oxycodone, and morphine are Class 2 drugs and should be closely monitored. In my home state of Florida, I only give a 30-day supply, and in fact, I am required to do drug testing on these patients to make sure that A, they're taking their medication, and B, they're not abusing other medications. Other avenues include anti-anxiety medications, sedatives, and hypnotics, which may also be useful for some patients. If those treatments fail, injections of either corticosteroids or hyaluronic acid could be used in certain cases. And once again, when the pain becomes intolerable, that's time to call up the local orthopedist and make a consultant visit for your patient to decide if joint replacement is the way to go. If you step back and look at the forest when you're dealing with osteoarthritis pain management, you see that we should take a stepped care approach. This is true when we treat hypertension or diabetes, and osteoarthritis is no different. Try to use the least addictive and the least potentially harmful med, then work your way up from the non-opioid to the weak opioids to the stronger ones. Start low, progress slow.